Okay, thank you for being here. I'm Yannick Hansenne. I'm head of critical care nursing in Malaysia and Belgium. So my declaration are there. I receive an honorarium from GE Healthcare, and I'm a user of GE Healthcare and Ascom products. Sounds familiar, isn't it? It's a bit like home, but we are used to it. We are used to have alarms, and they can be challenging, especially specifically for the patient safety. They are useful, but by increasing the noise level, they trigger many problems like hypertension, cardiovascular hazards, sleep deprivation, and specifically for our ICU patients, they can increase delirium and increase the length of stay. We already know the work of Elie Azoulay about PTSD, and the sounds and the noise in the ICU can increase the risk of PTSD. But the noise in the ICU is also a problem for the staff. They can lead to a lack of concentration, a stress, irritability. And ICUs are very busy environments, not only because of the alarms, but also because of the materials and the instruments we are using it. The ventilators, the pumps, the hemofiltrations. And in Malaysia, we had a dream. The dream of the sound of silence. This dream was the dream of lowering the burden of the noise for patient and staff, decreasing the alarm fatigue. So we equipped our ICU with Digistat system, and it's a system that's able to transfer the alarms from the bedside to a pocket-sized device called the Mycos. They are similar to phone, and they go in our pockets. You must know that in Belgium, the law says that one nurse take care of 3 patients. So let's say that with 96% of occupancy in our ICU, our hands and our pockets are full of alarms. So to help identifying alarms more efficiently, whether sooner or with less noise for everyone, we try to put the device in use. But you can't throw those devices like this in an ICU. I know that because we tried. During the COVID, we've done it because it was a brand new hospital beginning with the COVID. And we said, okay, let's do it. Let's put a device to help us. With the best device on the market, I can say you that it won't work. So after the COVID, we started over. It was a false start, and we began to do it more efficiently by identifying which device to include, which pumps, which ventilators, which hemofiltrations. We wanted to know which alarms, which alerts, how to escalate the alarms to the nurses, and how to prepare the staff. And we wanted to go for a simulation. And after that, we went live. But practically, how does it work? You have an alarm at the bedside, and this alarm sets off an alarm in the device, in the pocket of the nurse. She has 3 options that you can see. She can accept the alarms. When she accepts the alarms, she become the owner of the alarm. She must take the alarms, assess the patient, and stop the alarm. If she can't take it because she's doing something, she declines. And if she declines, the alerts goes to her fellow nurse that has the 3 other patients next to her. If she is not able to take any action because she is already doing resuscitation on a patient, she do nothing, and after 1 minute, the alarms goes on the second device. And the scheme is the same. The second nurse can accept, decline, or have no action. If she declines or have no action, the alarms sets off on every device on the ward. It's called the catch net because it's like in the circus when you fall into the catch nets. But there's a new toy in town. But is it useful? Do we use it? So we had an opportunity to study the impact of the noise in the ICU because one of our staff nurse is doing a master thesis. And she came to me, "Do you have a topic for me?" "Sure, I have. Let's study the noise in our ICU to see if the device is useful." So we did a pre-experimental study. The population was the patient in the unit. We excluded some rooms that were architecturally different of the others. And the tools were a questionnaire and a sonometer that we put in the rooms for 24 hours. So the different steps of the study were we measured the usual noise without any device. We trained the staff to use the MyCo, and we went live. And the second phase began. We put the use of the MyCos. We used them for 1 month, and after 1 month, we again measured the sound in the rooms. What we found is here. The peaks and the lows were the same, but the mean was significantly different with and without the MyCos. So we could deduce of that either the number of alarms or the duration were lower. Thanks to the statistical tool provided in Digistat, we compared before and after, and we saw that the number of alarms were the same. So we can deduce that the duration were shorter. With this tool, we can access valuable data and we can export it. Like, for example, here you can see a PDF, but you can also export information in CSV for studies or other thing like that. The impact of the device is promising. Yet we have hard times changing the mentality towards the device. It's the main challenge of our ward, is to increase the adherence of the staff to the device. Let's face it, it's a smartphone like in your pocket, beeping, vibrating, blinking lights with other alarms around you. It's a bit more alarming for you. And as you can see, some members of the staff think it's annoying. And one of the main problems is that they have the feeling that they are taking others' alarms. So, to lower this feeling, we set rules. Those rules, you know them, because they are best practice rules. Put the right settings of your alarms. When you hear an alarm, you shut it off. And the best and my preferred one is prevent alarms. Don't let alarms set in even if you are in the room. And one of them also is the team spirit. Use the device and take your alarms so the others don't have to take it for you. With the questionnaire, we had a result that is showing something is interesting. The staff thinks for 62% that it can reduce the noise in the ICU. And it makes sense. There's a study that says that with 11 decibels lower, the performances are the same. And with multisensory devices like we have, blinking, vibrating, and alarming, there's a better management of alarms. Another achievement that we have with this device is a collateral benefit. When you have something that is annoying you in your pocket because it's alarming you, but it's alarming you for nothing. You have a saturation of 82% of your patient that is set for alarming. And your patient is going 81, 83, 81, 83, but you take no action. Why? Is your setting is 82. So they have learned to better set their alarms. The perspective that we have for our ICU is to now decrease the noise in the rooms, because during the study we didn't move the volumes of the alarms in the rooms. We are going to do it. We are going to decrease from 2 notches the volumes in the rooms, so the patient will be in a less noisier environment, because that's what we are looking for, comfort for our patients. But doing this, the staff must know that they can be arms to the patient, because if they don't use the device, they will not be alarmed because they won't hear it. So it's something that they must be aware of. We are going to put some other alarms on the device. For the moment, we have only critical alarms, red alarms. Probably that we will go for mean alarms that will blink yellow instead of red. The sound will be different, and we can be alarmed differently with those different levels. We have also opportunities. Those opportunities is to have the waveforms of the SpO2. When you take the alarm SpO2 low, you push a button on your device and you see the waveforms. So you can say, I have a flat line. My patient only took out his device. If you have a real waveform, you can say, okay, there's a real problem. We will have NFC tags in the room. So when you know that you will be busy preparing your patient to go to the scanner or something else, going out with the patient out of the room, you prepare your patient, you take the device, you scan the NFC tags, and the device is shut down, so the alarms goes straight to your fellow nurse. You can have communication app, like it's a text messaging, and you can also have nurse call information. Your patient calls you, it comes in your pocket. It doesn't alert everybody in the room. And finally, in 2025, we'll double the capacity of the system, because we will equip the other half of our ICU. So we'll have our 48 beds equipped. Thank you for your attention.